Hello, everyone. We're here today with GU Oncology Now with the ASCO Bladder Roundtable discussion. My name is Vadim Koshkin. I'm a GU medical oncologist at the University of California, San Francisco, where I help co-lead the bladder cancer program for the medical oncology side. And we have a great panel with us here today, and I'll let the panelists introduce themselves, starting with Matt.
Hi, I'm Matt Zibelman. I'm an associate professor of GU Medical Oncology at Fox Chase Cancer Center in Philadelphia and director of clinical research of the GU service line.
Hello, my name is Cora Sternberg, and I'm a genitourinary oncologist and professor of medicine at Weill Cornell Medicine. I'm also the clinical director of the Englander Institute for Precision Medicine at Weill Cornell. Happy to be here.
Hi, I'm Dr. Dan Petrylak. I'm professor of medicine and urology at the Smilow Cancer Center, Yale University, and happy to be here as well.
Great. Well, again, a wonderful panel here, and our topic here today is really the treatment strategies for advanced bladder cancer for a patient population that's not eligible for any platinum-based therapy. So usually with significant renal dysfunction, for instance, like the dialysis patient, Cora, you mentioned. What is your frontline treatment at this point, or how do you approach such patients? Do you see a lot of those patients?
I usually give them immunotherapy. We published the SOL study, and we have a poster updating it here at this ASCO, in which we allowed patients with inflammatory disease, and patients with poor creatinine clearance, patients on dialysis, patients who generally were not eligible for any of the registration trials. And we found that the results were pretty much similar to those in the registration trials. The ones who did the worst were the ones with brain metastases and the ones with PS of 2. And again, PS of 2 is something subjective. I would imagine that, many countries, they didn't have anything to do. Maybe this was PS3. It's very subjective. But those were the two groups of patients who did the worst. The ones who really did the best were the ones who had inflammatory disease, which gives me a lot of courage because I have patients with colitis, which you normally wouldn't put them on immunotherapy, but now I have the courage to do that. And I have, working with their gastroenterologist or working with their other pulmonologist, have not had problems giving immunotherapy to patients with inflammatory disease.
Is there still a large patient population you do give just checkpoint monotherapy to in a frontline setting?
Well, I was until just now when the Pembro-EV was just approved like a few weeks ago, but I was giving patients coming in with comorbidities, elderly patients, poor performance status. Yeah. We get patients in the 80s and 90s coming into Weill Cornell and want to be treated. Yeah. And
you would consider those patients for enfortumab pembrolizumab now, instead of just
would now.
Okay. Is that the consensus?
Yeah, I think for most patients, I think that would be what I would offer them. If there were potential comorbidities, really bad neuropathy, maybe, and maybe you would think about pembrolizumab alone. But I think for most, I think that would make sense.
There are few patients who are truly platinum ineligible. Very few. I mean, you can count them on one hand, basically.
Yeah, so it is a limited population, but it sounds like even to this population, the EV Pembro data we can extrapolate.
Especially if some of their problem is related to the disease, right? If their performance status is low because of symptoms related to the disease that you can potentially improve with good systemic therapy, I think obviously that's worth trying.